Welcome back to the deep dive. For anyone getting ready for board exams, we're doing a laser-focused session today. Tendon healing essentials.
Right.
This isn't going to be a general overview. We're going deep into the anatomy, the physiology, and, the clinical insights that really drive modern hand surgery.
Exactly. The goal here is to connect the dots. You've got all these scattered facts about collagen types, vascular zones, rehab.
Mhm.
We're going to pull it all together into one story.
But coherent narrative.
Yeah. If you walk away from this understanding why intrinsic healing is so important and why we mobilize early, then you've basically nailed the entire topic.
Okay, let's unpack this. So let's start at the absolute foundation, the building blocks. What are the essential components? I mean, beyond just saying it's connective tissue, what does a resident absolutely have to know about a tendon structure?
Okay, so the absolute key, the thing that gives it its strength, is its composition. It's dense, it's metabolically active, and it's built from primarily type I collagen.
That's the big one.
That's the big one for mechanical strength, for tensile load. It's structured, it's robust. Now it's about 95% type I, but you do have to remember there are small amounts of types 3 and 4.
And we'll come back to type 3 later, because that's a huge part of the repair story.
It is. It's the hallmark of early weak repair.
So you have the structure, but you also need the cellular workers. Tendons are, relatively hypocellular, but the cells that are there are critical.
3 main players you need to know.
Right. We've got the tenocytes, which are the specialized tendon cells maintaining that type I matrix. Then you have synovial cells, obviously key for sheathed tendons. And then just your general fibroblasts,
The repair crew.
the essential repair crew that comes in after an injury.
So from the components, we move outwards to the protective layers. This is an area that can get a bit confusing for people.
Yeah, the different sheaths and coverings. How do we break that down simply?
Let's start from the inside out. The innermost layer is the endotendon. It's what wraps the individual tendon bundles.
And it has a really critical structural role, right?
Wow.
It's continuous with the muscle proximally and the bone distally.
Exactly. It's continuous with the paramecium and the periosteum. That continuity is the mechanical handshake. It's how muscle force gets transmitted efficiently to the bone.
Okay, so then we move to the more external layers.
Yeah.
And this is where that distinction between synovial and non-synovial tendons really starts to matter.
It does. For synovial tendons, the ones that glide in a sheath, their specific outer layer is called the epitenon.
Okay, epi for synovial.
And for the others, the extrasynovial tendons, you have the peritonon. It's a much looser adventitial layer.
And the high-yield point here, I think, is that both of those layers, the epitenon and the peritonon, they contain blood vessels.
Yes, which makes them really important players in the whole vascular supply story and, critically, for the extrinsic healing mechanism we need to talk about.
Perfect lead-in. That brings us right to vascular supply. Because knowing where a tendon gets its blood or doesn't defines everything about how we manage it.
It really does. So let's start with the flexors. They're notoriously tricky. What are the 3 primary sources of blood supply we need to have memorized?
Okay, so you get it for 3 places. Proximally from the musculotendinous junction, distally from the bony insertion, and then the most famous one along its length from the mesenteric vincular vessels.
The vinculae.
Yeah.
Long and short, they are the absolute lifeblood for the middle part of the tendon.
But, and this is the classic board question, there's a catch.
There's always a catch. Despite those 3 sources, there's an unavoidable avascular zone.
And specifically on the volar surface, the friction surface.
Exactly. The gliding surface.
So what of that is massive. It's why zone 2 no man's land is such a nightmare. You're trying to repair something in an area that's naturally ischemic and prone to scarring.
You're fighting biology from the start. High friction, poor perfusion. It's a recipe for adhesions.
Okay, so how do the extensor tendons differ? They're usually a bit more forgiving.
A bit. Their supply is similar. Musculotendinous and bony insertions are still there. But the big differences are on the dorsal side. Extensors have a long mesotenon within their synovial sheath.
And crucially, what are they missing compared to the flexors?
They're missing that dedicated vincular supply system. There's an absence of the vinculi.
Which brings us to some high-yield anatomy. The 6 extensor compartments over the dorsal wrist. You just have to know them.
You do, but instead of just listing them, let's group them by function. It makes it easier to remember.
Good idea. So you have your thumb movers, wrist movers, and then the finger extensors.
Right. So compartment 1 is your main thumb group. Abductor pollicis longus and extensor pollicis brevis. APL and EPB.
And if you know compartment 1, you immediately know why De Quervain's tenosynovitis presents as pain right over the radial styloid.
That's the clinical hook, exactly. Compartment 2 holds the main radial wrist extensors, the ECRL and ECRB.
Okay, then back to the thumb, but deeper.
Compartment 3. That's dedicated just to the extensor pollicis longus, the EPL. It's the one that hooks around Lister's tubercle.
Essential for understanding attritional ruptures after a distal radius fracture.
For sure. Then your central workhorses for the fingers are in 4. Extensor indices and the extensor digitorum communis.
Fifth compartment is easy. It's just the little finger's independent extensor.
The extensor digiti minimi. And finally, compartment 6 on the ulnar side houses the extensor carpi ulnaris, your ECU.
That's your six-pack. You have to know it for trauma, infection, anything on the dorsal wrist.
Okay, let's pivot, because this next part is the real conceptual leap in hand surgery, the mechanisms of healing.
Extrinsic versus intrinsic. This distinction literally changed everything about post-op care.
It did. The original historical understanding was all based on extrinsic healing. The idea was that healing depended on fibrous attachments forming between the tendon and the tendon sheath.
So it had to scar in from the outside.
Right. And if you believe that's the only way it can heal, what's the logical next step?
You immobilize it, you cast it, and hope the external scar tissue bridges the gap. The problem, of course, was you got a stiff, non-functional hand.
Disaster. But then our understanding changed with the concept of intrinsic healing. This was revolutionary.
So this is the idea that the tendon can heal itself from the inside out.
Exactly. It depends on the tendon's own cells, the tenocytes, doing the repair. And for that, they need 2 things: blood flow from the vinculae and diffusion of nutrients from the synovial fluid.
Here's where it gets really interesting. What was the definitive proof for this? The elegant experiment that changed the game.
It was Lundborg's study back in the 70s. It was just a brilliant piece of science. They showed that a severed tendon could heal even when it was wrapped up.
Wrapped in a semi-permeable membrane, right? And then placed in a rabbit's knee joint.
Yes, and that membrane is the whole point.
Because it let nutrients in.
It let the nutrients in from the synovial fluid, glucose, amino acids, all the building blocks so the tenocytes could work.
But it kept the external cells out.
Crucially, it kept the external cells out. No fibroblasts from the sheath, no inflammatory cells, creating that extrinsic adhesion-forming cascade. And the tendons healed.
They healed on their own.
They healed on their own. It proved, without a doubt, that tenocytes could do the job if you just gave them the right environment. That single study overturned decades of practice.
And directly led to the early mobilization protocols we use today. It's just a fundamental shift.
It is. So now that we have the 2 pathways, let's quickly run through the phases of healing. They mirror general wound healing, but the specifics are testable.
Okay, 3 phases. Phase 1 is inflammation. This is immediate, lasts a few days. Inflammatory cells rush in, clean up debris, and what else?
They secrete growth factors. And those growth factors are basically a call to action for the fibroblasts.
Attracting the repair crew, which leads to phase 2. Proliferation.
Right. This is from about day 4 up to, say, 2 or 3 weeks. The fibroblasts are now on site and they start churning out new tissue. Mainly 2 things: type 3 collagen and GAGs.
And what's the critical feature of that type 3 collagen?
It's weak, it's laid down randomly, it's disorganized. So the tendon at this stage lacks strength. This is the most vulnerable period for re-rupture.
A dangerous window.
Absolutely. Which brings us to the most important transition. Phase 3, remodeling. This starts at about 3 weeks post-injury and can go on for months.
This is where the quality of the repair really improves.
It does. The weak, random type 3 collagen gets systematically replaced by the strong, organized type I collagen. And the tendon starts to remodel and align along lines of stress. That 3-week mark is key.
Okay, let's tie it all together. We know intrinsic is better, and we know the repair is weak for 3 weeks. So what's the relationship between early motion and these 2 healing mechanisms?
It's a calculated trade-off, like you said. Early controlled motion does one primary thing.
It limits the formation of those fibrous attachments between the tendon and the sheath.
So it actively discourages extrinsic healing. It discourages the bad pathway, yes. And by doing that, you're inherently promoting the intrinsic pathway, which relies on that synovial fluid diffusion. And the motion itself helps align the new collagen fibers correctly.
So the final takeaway, the conclusion that validates every modern protocol from Duran to Kleinert,
is that mobilized tendons are definitively stronger. They have fewer adhesions, better glide, better function, period.
So what does this all mean?
It means you have to manage that critical window. You're trying to get from that weak, random type 3 collagen in the proliferation phase to the strong, organized type I that starts showing up around 3 weeks.
And the only way to do that successfully is to promote intrinsic healing. That's why the early mobilization protocols make perfect sense. You're minimizing the scarring that would ruin everything.
Exactly. The whole challenge is balancing that need for motion with the risk of rupture while the repair is still weak.
So a final thought for you to take away. Considering this huge distinction between intrinsic healing from diffusion and extrinsic healing from scarring, how might that knowledge guide your choices in the OR? When you're selecting suture material or the type of repair, how can you prioritize minimal friction to maximize that nutrient diffusion? That's something to mull over.
That's a great point. That's where theory meets practice.
That wraps up our deep dive. Keep studying smart.